They have unrealistic expectation. They are not actually looking for what the surgery is meant for.
How do you decide once you have sufficiently optimized the surface? Because you're not going to get it perfect.
Any dry eye or any surface inflammation needs to be treated first for the best outcomes.
From the 7th annual winter meeting of the IIRSI in beautiful Amritsar, I'm Josh Young. I'm here with my friend Himanshu Matalia. Himanshu, you're talking about an important subject, which is the refractive surgery patient and your concerns and the parameters that you're looking at pre-op. Actually, it's a very, very complicated, it's a very complex field. Let me get you, first of all, to simplify it, to sort of lay out the landscape, and then I'll have more questions.
Thank you, Josh. Good morning. Josh, it's a very interesting thing that we are dealing with patients here who are absolutely normal. They are young people with good vision, and we should be very careful dealing with them because many time, if we are not careful, we may end up in sorry situation, and we know that we better be safe than sorry. These cases are normal cases, and hence it's all the more reason that we should be very vigilant by selecting the proper case. So when I look at my patient, when the red flags on my things start from the counseling. When patient comes, and if I see that during counseling they have unrealistic expectation, they are not actually looking for what the surgery is meant for. Well, that's a big red flag for me. I would do a proper counseling and I make them understand what is this surgery for and what's the aim of this surgery. And if it's still not very comfortable for me, I would rather ask them to read about the subject and come back again one more day. I don't mind if they want to take another opinion, and that's absolutely fine with me. In fact, it improves my value because I know the next person may not be able to do better justice than what I would have done. So I'm absolutely great when they want to seek a second opinion. When I'm dealing with my patient, there are certain patients which are quite unique and I should be very careful about them. And one of them important thing which stands out is hyperopic especially. Now, hyperopes are somebody who are very unique because hyperopia is a dynamic situation. The power in hyperopia is very difficult to measure, and many times than not we end up giving a refractive error which may still have some latent hyperopia, and later on when we do the surgery there are very high risk of regression, there are very high chance of accommodation related abnormalities, and the quality of vision may be little less than optimal. Hence, well, these cases I would be very, very careful. When it comes to further while examining the patient, the ocular surface is something where I would pay a lot of attention to, and I would make sure that ocular surface is stable. Though mild dry eye may be a relative contraindication, Josh, but I would still say that any dry eye or any surface inflammation needs to be treated first for the best outcomes. And hence, if requires, I would rather do a complete nice dry eye workup. But the one test which excites me most and which I use absolutely invariably in my clinic is humble fluorescence staining. Stain the cornea, stain the ocular surface, and see them with yellow filter, which brings up the entire universe in front of you, and you can see many times things which were actually invisible. So I do look at the stability of ocular surface. Uh, Coming to the dry eye patients, well, if there's significant dry eye and if it's not under control, I might not be very keen on laser vision correction, and then we may think of treating the dry eye optimally with systemic treatment or systemic investigation, whatever is required, but then go to the laser vision correction at the second step and not primarily at the first go. Uh, Coming to further down to the cornea. Now, we know that for us corneal surgeons or for us refractive surgeon, our nemesis is missing out on a corneal ectasia and doing a laser vision correction on these cases. Many times these cases are straightforward and you can pick up the ectasia from the corneal topography. But sometimes they may not be as obvious in front of you in terms of topography. Be very careful. Whatever criteria you are following, whether you are following Bradley Randman's criteria or whichever criteria you follow, but stick to that. Make sure that if you have the opportunity to possibly go for a better test to confirm your diagnosis, go for it. uh, Many times than not, when you have doubtful case and when you do something like corneal biomechanics measurement and you realize that the biomechanics of the cornea was actually less than optimal. Now, here are the cases where you are dealing with a possible case which is not still full-blown ectasia, but which has the corneal biomechanics which is poor, and on the same time the corneal topography is doubtful. Well, I would be very much careful about such cases. I would rather select a non-laser vision correction based, or if at all, it would be surface treatment, because my chances of ectasia would reduce as much as possible. The cornea also can be sometime the culprit for in terms of epithelial healing issues. So I would be very careful about cases where there are epithelial basement membrane dystrophy. Sometimes it may be very obvious, but the other dystrophies which are not very obvious, or if there is endothelial dysfunction like Fuchs endothelial dystrophy, well, that's a big no-no for me, and I'm not going to touch those cases. Going further down the lens part of it, of course, the obvious cataract is absolutely no, and we would not be taking them up for the laser vision correction. But sometimes it can be very subtle, and sometimes these early cataracts can be missed, and their dysfunction lens index DLI on an eye trace can actually work very well and can help you to detect those internal aberrations arising from the lens. I would also keep in mind if there is a disparity between subjective and objective refraction, where Josh, we would surely want to make sure that there's not much accommodative component there, or in worst case scenario, we're not dealing with displacements of the lens where lens may look clear, but there is a subtle displacements of the lens, and I would be very, very careful about that. Of course, any posterior segment abnormality and which is not going to help the patient by doing laser vision correction is absolutely no for me.
So this is very, very interesting, and a lot of the things that you bring up are sort of universal truths, because when we have the patient coming in with ocular surface disease for cataract surgery, it's the same issues too. So I'm going to ask you a question. My contention is that there's no answer to it, but I'm not a shy guy. I'm going to ask you anyway. If I have someone coming in for biometry for cataract surgery, let's say, and there is a clear influence from a dysfunctional ocular surface, the topography doesn't look regular, and I like you, I pull out all the stops. I'm going to do topical anti-inflammatories. Maybe I'm going to put in buccal plugs. And I'm going to send the patient out to come back, I don't know, maybe a month later or something, which is, of course, very frustrating for the patient. Although I know if the patient winds up in someone else's office, then it's someone else's problem at that point. But my question is this. So the patient comes back for the second visit. The topography is better. It's not perfect. How do you decide once you have sufficiently optimized the surface, because you're not going to get it perfect, that you can proceed with surgery? Do you need, serial topographies that are not changing? I mean, what do you do?
Sure. That's an excellent question, Josh. And I always believe that there's always any point estimate or any diagnostic device will have test retest variability, will have repeatability issues. So I always do 3 scans at any point of time whenever patient comes. So I know that those intertest variability are there in front of me. Also, whenever I repeat a topography, and if there is a significant change between two topography, I would ask for one more topography, which is that 6 weeks apart, and I would like to see two stable topography or two stable refraction. Without that, I'm not going to touch the patient.
Yeah. Also, I mean, obviously, the reason to do it is the reason that you say, but also, I think to some extent, it conveys to the patient how serious you are. You know.
Very true.
Anyway, these are, as I said, universal truths. I'm so happy that and it's a lot of moving parts here, very complicated. I'm so happy that you made it so clear, and. Himanshu, I want to thank you very much for looking at this topic and talking about it. But most of all, I want to thank you for your generosity of your time with me today.
Thank you so nice of you. Thank you. Thank you.
Thank
So
you.
much. Thank you.